Welcome to Trying to Conceive with Dr. Sasha Hakman, where we break down the science of fertility, share real patient stories, and explore the latest innovations in reproductive medicine. My name is Dr. Sasha Hakman, and I'm a double board certified OBGYN and reproductive endocrinologist and infertility specialist. I practice at HRC Fertility in Beverly Hills, but this podcast is an independent project created and hosted by me, separate from my clinical work. Don't forget to subscribe so you never miss an episode. And if you want exclusive updates and resources, be sure to sign up for my newsletter. Just click the link in the episode description. Okay, so today we're going to talk about whether or not you should delay IVF or egg freezing to improve egg quality, and whether or not this delay can positively or negatively affect pregnancy outcomes for IVF, whether this varies by age, and will leave you with practical tips to maximize treatment outcomes if you're actively going through IVF or your egg freeze process. Today, I have a really special guest. I have Dr. Phil Romanski, who is a reproductive endocrinology and infertility specialist that's double board certified at RMA of New York in Manhattan. He's an assistant professor of obstetrics, gynecology, and reproductive science at the Icahn School of Medicine at Mount Sinai. Dr. Romanski completed his residency in OBGYN at Harvard Medical School and his fellowship in REI at the Weill Cornell Medical Center. Dr. Romanski additionally serves as the Associate Research Director for U.S. Fertility and has authored over 60 peer-reviewed research publications with a particular interest in patients with a history of unsuccessful treatment and patients with diminished ovarian reserve. In recognition of his research contributions, he's received multiple national awards and has been invited to speak at national and international conferences to present his work. He is an expert in family building, including the evaluation and management of female and male infertility, third-party reproduction, and fertility preservation. Welcome.
Thank you for having me.
That's great. We've known each other for many years now.
Indeed.
Same sort of graduating class for fellowship, which is really cool to go through the whole process together.
I know. I can't believe we're here. It's been such a long time knowing each other.
Yes, it has been probably 7 years now?
At least, yeah.
At least. Kind of wild.
Yeah, definitely.
And you're doing amazing stuff.
Yes,
I often cite your research to my patients when doing some counseling.
Yeah, good.
So
I'm glad it's been helpful.
You're doing amazing stuff.
Thank you.
I love this topic because, at least for me clinically, and I'm sure you deal with the same, I have a lot of patients who come for their initial consultation. They're interested in pursuing IVF, whether it's for fertility preservation with their partner or because they need it for various treatment, or even egg freezing, I would say is the most common setting where patients actually want to delay starting their treatment or their ovarian stimulation by at least 3 to 6 months in hopes of improving their egg quality. And so there's always this common battle of whether or not you should be doing that. And is there ever a setting where that is both either recommended or discouraged?
Yeah, you're right. I think it's something that we see more and more, especially as patients come to us with a lot of knowledge, with a lot of education. A lot of patients do so much research before they even meet us. They're asking all the right questions and they're aware of these different interventions, some that may work, some that might not work, to help optimize their outcomes, to help, improve their overall general health, their overall reproductive health. And so the question becomes, how do we proceed from here? Which of these interventions make sense to apply? And is there some period of time that we need to wait to allow these to have their maximal effect before starting fertility treatments?
It still remains somewhat controversial.
Yeah.
But to start, how about we start by defining the role of AMH and testing your ovarian reserve?
Yeah, sure. Yeah. I mean, that's a great place to begin because that's one of the mainstays of fertility evaluation. People will come in and ask, can you test my fertility? And the answer to that is, unfortunately, no. There's no good way of testing fertility short of trying to conceive on your own. But we can check what's called the ovarian reserve, which is essentially the number of eggs that somebody has remaining within their ovaries. I generally explain to patients that the way the ovary functions after birth, it stops producing new eggs. So if a patient sitting in front of me, she's 35 years old, I would say, the eggs within your ovaries right now, they're 35 years old. They've been there with you your entire life. Those eggs.
I love that way of putting it.
It sort of hits. These eggs have been through A lot. The eggs are single cells and cells are fragile. While their quality is good for the first few decades, over time, there's a decline in the number of those eggs because there's nothing being produced to replace them. What we partly want to understand is how many eggs somebody has remaining. And there's multiple ways to test that. But one of them is to do an ultrasound. We commonly look at the ovaries, and patients might see us counting what we call the antral follicles. A good way to think about that is that within the ovaries, there's generally, tens of thousands of follicles. They're microscopic, they're primordial. We cannot visualize them, they're too small.
Right.
But what the ovary is doing is constantly recruiting a group of them to start to develop. As they develop, they enlarge, they fill with fluid, and those are the ones that we can see. And I explain to patients that the more eggs they have within their ovary, the more of those follicles that get recruited at any given time. So that's why we're able to look at the ovary and understand that number there, an estimate of that patient's ovarian reserve, whether that's what we expect for their age, maybe it's more than expected, sometimes it's less than we expect. And then those follicles produce the hormone AMH, anti-Müllerian hormone. So we'll then check that, usually in the serum through a blood test to see what that level looks like. Using the AMH level, using the follicle count, we can have a good sense of what somebody's ovarian reserve is, how many eggs they have remaining.
For patients that usually ask about their FSH levels, which stands for follicle stimulating hormone, which does exactly what the name implies, it stimulates the follicles to grow. And usually early on in the menstrual cycle, we expect FSH to be low. Oftentimes patients will say, you didn't check my FSH, but the last clinic did. I usually tell patients, unless they have really low ovarian reserve, we're really trying to check, are they entering that perimenopausal state? Then it really doesn't tell us too much if they have good ovarian reserve.
Yeah, I tend to agree with that. I place less emphasis on that hormone value. It's just less specific for the information that we're trying to identify. What we really want to understand with the ovarian reserve numbers is if a patient is going through fertility treatment, how likely are they to respond? And that's where these numbers come into play. The FSH is just less useful to predict or to use that for counseling. So I find the AMH and the follicle count to be the most clinically useful measures that we have.
Yeah, I love that. Now, I know you like to work a lot with diminished ovarian reserve, and we have a lot of research out there that shows that diminished ovarian reserve does not necessarily correlate to pregnancy outcomes or the chance of live birth, even if you're doing IVF. How do you counsel patients on what to expect, particularly in the setting of fertility preservation, if they have diminished ovarian reserve?
Yeah, so, I always explain to a patient when we're doing this testing, this will there's certain things that this test will tell us, and there's certain things that it cannot tell us. And so I tell them that if it comes back, above average, below average, that doesn't mean anything for your fertility. If you were to start trying to conceive next month, as long as you have regular menstrual cycles, no matter what your AMH level is, you have the same chance of getting pregnant as anybody else your age. Success rates are primarily driven by the age of the egg. That correlates well with egg quality. As long as somebody has regular cycles, they're releasing one egg every month, it doesn't really matter what's remaining within the ovary. They have that one chance each month, just like everybody else. What diminished ovarian reserve does tell us is that potentially that patient could have a shortened reproductive lifespan. But I always emphasize, we still don't know that. Patients with diminished ovarian reserve will follow for 5-10 years. They continue to have regular cycles. They're able to build their family. If they hadn't otherwise tested it, they would never have known that number was lower than average for their age. Because ovarian reserve is declining over time, when we find the reserve is low, it could mean one of two things. Number one, maybe that patient just started out with less eggs, average person, but they're on kind of a very slow, gradual decline, and they're going to, end up at menopause at the same age as most people, around age 50. Or number two, there's another population that started with a high number of eggs, but is on an accelerated decline. But being able to tease apart which group they fall into from a single time point is not possible. We could only know that if we continue to follow that hormone over time to have a better understanding of that. So it's difficult when a patient gets that information that their reserve is low. It can be alarming. People worry that they're not going to be able to have children, that they're not going to be able to have the family that they always dreamed of. So it's always a long conversation about how does this apply to my future fertility? How can we use this information today? And what do we still not know? Then we start talking about, okay, the ovarian reserve is low. Maybe this is a patient interested in pursuing fertility treatment or egg freezing, for example. The next thing we have to talk about is how that impacts what the expected outcomes are going to be from a fertility treatment cycle.
It's always tougher with egg freezing specifically because we have no idea what journey that egg is going to take. If you have a smaller quantity to start out, we have no idea what sperm is going to look like when the time comes. I mean, if you end up using donor sperm, then more likely that it's going to be a better outcome, but there could be male factor. And then we also just don't know the quality of the egg because until it goes through its journey of creating an embryo and then being transferred back to the uterus, it's just a big question mark.
Yeah, I think that's a question many patients ask. Is there a test for egg quality? Just like this test you're telling me about for egg quantity, we can check my AMH. What can we do for egg quality? And like you said, there's no way of knowing that because the egg is a single cell. Sure, we can check the quality of that egg, but then that egg is now, destroyed in doing so.
Right.
So we just have to assume that the quality is correlated with that patient's age. And for the vast majority of patients, it is. It's pretty rare to see a patient with an accelerated decline in egg quality. But as you said, we only understand that information once we're usually fertilizing those eggs, seeing how those embryos are developing and seeing what the quality looks like at that point.
Yeah, absolutely. I tend to use the sort of calculators to predict based on age how many eggs you would need to freeze to give an estimated chance of 1 versus 2 versus 3 live births. Do you ever use that for counseling patients?
Yeah, I do. I think those tools are very useful to give a patient a visual, sort of a hypothetical but real example of how these numbers play out in real time. It helps them to conceptualize how these eggs ultimately turn into embryos, ultimately turn into a live birth. So to give them some idea of what is a reasonable target, I'll do similar to that, where we'll look at the calculator together, put in their patient-specific parameters that are going to impact the success rates, and then we'll put in some examples. Okay, let's imagine you have 10 eggs from your cycle. I'll put that into the calculator, and that gives you X chance of a live birth. Let's change that to 20. Let's change that to 30. In that way, they're understanding how more eggs we freeze, the better chance of success. But up to a point, it sort of starts to plateau eventually. But still, it's hard to think long-term about what that actually means because we don't really know how many eggs we might get from an individual cycle. The best way we have to estimate that is the ovarian reserve numbers. So I can usually give a patient a good sense of how many eggs they're going to expect. Of course, some patients will respond a little better than that, a little less than that. But then I always explain what we do in reality is we'll do the first cycle. That's all we can control, one step at a time. See how many eggs we actually end up with, and then we'll put that number into the calculator. Then we can double that and help the patient understand. If I did a second cycle and have a similar outcome, this would be kind of the improved success rates for me down the road. And I think that really helps patients to think about whether they want to do another cycle or maybe they're happy with the success rates that they've achieved from the treatment that they've already done.
Yeah, absolutely. I usually take that same approach where it's one step at a time, especially because some patients, I've had patients with very low AMH respond so much better than I could have ever imagined. And I've also had patients with a higher ovarian reserve where the response is just not that good. And it always sort of kind of go back to the drawing board. Like, should I keep the protocol the same or switch it up? What's going on here? You never really know what you're going to get until you actually go through with the cycle and you do the retrieval.
I always explain to patients, that's why they're seeing us. When things aren't going as we predict, that's where we're the most useful. We can really start to do a deeper dive into what's actually changing with their hormones and figure out what changes we need to make to the medications, to the protocol, to help give them the best outcome.
Yeah, I like that perspective. You published a study back in 2020, right? I guess around the time of the pandemic.
Yes, exactly that time.
Titled Delay in IVF Treatment Up to 180 Days Does Not Affect Pregnancy Outcomes in Women with Diminished Ovarian Reserve. I thought that was a great study. Can you tell us more about it?
Yeah, so this was a study that actually was born out of the pandemic because there was a time where very quickly IVF clinics were having to shut down, for a short period of time when medical resources were scarce. And our
caused mayhem for patients.
Yeah, big time. Rightly very concerned about these delays that could be impacting their treatments, their success outcomes. And as physicians, we were very concerned about this as well. Whenever a patient is ready to start treatment, we always want them to get started as soon as they can to continue their journey. I tried to think, what is a way that I could study that retrospectively using patients who have already come through the clinic, who have already done treatment, to understand if there are short delays in treatment, does that have a clinically meaningful impact on the patient's outcome? And so I try to think, okay, we could look at this for all patients that come through the door, but we already know that young patients with good ovarian reserve, with good egg quality, if they delayed treatment by 3 months or 6 months, we're not going to see a clinically meaningful decline in their success rates because their egg quality is so stable, at younger ages in the early 30s. But it was really the more vulnerable populations that we were the most concerned about. Patients in their late 30s, early 40s, patients with low ovarian reserve. These are the ones who that decline could potentially impact their success. And so that's the population that I decided to focus on, looking at patients with diminished ovarian reserve, essentially. So patients that had an AMH level less than 1.1. Those are patients that generally we would call a poor responder or somebody who might get fewer eggs during their treatment cycle. And so I took those patients with low AMH levels and I looked at, okay, 2 different groups. The first group of patients were those who came to the clinic and did their initial evaluation and then were ready to start treatment right away. So those were patients that started their IVF cycle within 3 months of their initial visit to the clinic. And then I took the second group of patients with the low AMH, those who took a little bit longer to start their cycle for one reason or another. They were taking time doing their evaluation. They weren't quite ready to start infertility treatment. So that second group started their treatment between 4 to 6 months after the initial visit. And that was how I was modeling a delay in treatment. Just compared the outcomes from their IVF cycle. How many eggs did they get? How many embryos did they have? And ultimately, what was the outcome of the embryo transfers? Did they have just as good of a chance of having a healthy live birth, or were their success rates decreased because their time to treatment was delayed or took longer? Ultimately, reassuringly, what we observed and what we were hoping to observe was that that short delay, that 3-month delay, didn't have any significant impact. The chance of a live birth in that group that was delayed by 3 months was the same as those who initiated treatment right away. Then taking that a step further, I looked at a couple different subgroups, even more vulnerable populations. So I then specifically looked at patients with an AMH below 0.5, so really low reserve. And then similarly, I looked at patients who were above age 40, so patients who might have even lower egg quality. And the same results held. We saw that there was no decrease in live birth for patients who made that delay in treatment. That was huge for all of us to be able to reassure ourselves, to reassure our patients that ultimately we want to get you back into the clinic. We want you to be able to resume your treatments as soon as you can, but we want to do that in a safe way. And now we've got really good data to show that we can do that without having any impact, in your success rates. So that was really reassuring at the time. But since then, that paper can now be applied to many different scenarios, many different populations. There's lots of reasons a patient might decide to delay their treatment, as you mentioned. And as we'll talk about more, some patients are changing interventions, changing things in their lifestyle, and they want to give that time to take effect. A patient might see me and really wants to start treatment, but it's not a good time in their life. They've got something going on at work, something going on at home, and they're not able to get started for the next couple of months. And so they always want to know, if I start now versus if I start a few months down the road, is that going to be, a make or break decision for me? Do I need to make this difficult decision and tell them I can no longer do what I had been planning? Fortunately, with this data, it's reassuring that those delays generally don't have a significant impact.
Which is great, because I think particularly those who have a really terrible lifestyle and are trying to improve that, I think even just for the safety of treatment, that's great. So I'm talking more specifically, let's just say they have a BMI cutoff. Every clinic is different. Some clinics will go up to 45 or 50, but if you are above that cutoff, then you need the weight loss for anesthesia purposes. But then more specifically, a cessation of smoking cigarettes or marijuana. Perhaps somebody is consuming way too much alcohol or diving into lots of recreational drugs that they should be avoiding. But it's always this tricky situation because you have the same eggs you've always had. They have been exposed to these toxins it could impact egg quality. So what do you say to the patients who say, no, I've done my research. I know that most of these eggs are in the resting stage in these primordial follicles. And as it leaves that resting stage over the course of the next 3 to 6 months before it becomes an antral follicle, that's where I can really nourish the egg through supplementation and lifestyle. What do you say to that?
I think that's a great insight for patients to have that understanding. Yes, the eggs have been there throughout all of the exposures over their lifetime. There's nothing we can do about that, but there is that few month period of time where the egg within the follicle is developing from that primordial stage ultimately to the antral follicle, the dominant follicle, where lots of changes are going on within that specific follicle. Exposures during that time might have a greater impact than exposures that occurred during the primordial follicle stage. Lifestyle changes are great, but the impact doesn't happen overnight. The impact does take some time to see the full effect. It's always a conversation about how much improvement we could see from the changes compared to how much of a decline could occur with the egg quality or egg quantity with the amount of time it might take to make those changes. You brought up the example of a patient's weight. Sometimes weight can make it more difficult to go through fertility treatment. Patients don't always respond as well to medications in certain BMI classifications, or might have more of a difficult time undergoing anesthesia to undergo the retrieval. And so there are some scenarios where to optimize the outcomes, ideally, that patient might lose 5 or 10% of their body weight. But we know that can take a long time. It should take a long time, right? Exactly. And for some patients, that can take a year or more. There are some really good papers that try to compare the benefit we might see from that weight loss compared to the detriment that might occur if somebody was delaying their fertility treatment for a year or two to decrease their weight. In those scenarios, generally, there's more harm than good for having to wait that amount of time. So somebody who wants to be pregnant now have to put off building their family for a few years. Mentally, it would be difficult. Some of these interventions can be done a little bit quicker. That's a different scenario. Now we're talking about a period of only 2 or 3 months, which is a much shorter time. And I always tell patients that every decision I'm making as you're going through this treatment is I'm confident we're making the best decisions we can with the information we have, and that everything will be optimized for your outcomes. But I want you to feel that as well. And if a patient comes to me and says, just haven't been living a very healthy lifestyle, and I really want to make some positive changes in my life. I want to change my diet, my exercise habits, my social habits. And it's important to me. I understand, that this could take some time. I want to give myself 2 or 3 months to make those changes and feel as healthy as I can before going into this treatment. Then in nearly all cases, would 100% support that. Because I think in those cases, it's important for the patient to be in the right mindset. And in that period of time, those follicles that are developing are now being exposed to all those healthy lifestyle habits. So we know that we're going to get the best possible response. And we can also be reassured that within a few months, again, if that patient cycles next month, if they cycle 3 to 4 months from now, there's not going to be a clinically significant difference in the outcomes. I always encourage patients, especially those who are motivated to make those changes, to focus on that. We'll start the treatment as soon as they feel ready.
So we talked about ovarian reserve. Your study showed that if you delay treatment for about 3 months, even in more vulnerable subgroup populations, older women, like significantly diminished ovarian reserve, it doesn't really affect treatment outcomes. Although we suspect that if it's a much longer time period, it likely would. For those who are hoping to improve their egg quality for various reasons before they start their treatment, let's say they're going to delay by 3 to 6 months. What are some science-based recommendations that you give to patients to improve egg quality?
This is a great question because this is the modifiable factor. We can't change their age. We can't change their other infertility history, but these are the things that they can take control of, that they can modify to help improve their chance of being successful with treatment. And most of these changes, people are looking for that magic bullet, that one thing that they can do that's going to make the difference. And I think the important thing to understand is that probably doesn't really exist. It's more of a general approach, a general mindset that patients should have as they're trying to optimize their lifestyle, optimize their outcomes from fertility treatment. Just like patients trying to lose weight, you see these diet fads that occur over time. They all seem to work, but they're also different from each other. The main thing they have in common is that they bring mindfulness to the situation. Somebody's really focused on this particular goal, and so they're making the right choices. And they generally have some sort of healthy eating habits that help to lose weight. Ultimately, they're all successful for different reasons. And that's similar to the different ways that patients can apply some changes to improve their fertility, their reproductive health. So the obvious ones are the social habits, right? So we know high amounts of tobacco, drug use, these things are going to have a detrimental impact on egg quality and sperm quality. This is the part of the conversation where both partners need to understand this isn't just for the female patient to apply, but the male patient as well really needs to focus on removing those things if that's something that's in their life. And then alcohol use. The more alcohol somebody consumes, the lower chance that they're going to have healthy sperm, that they're going to have healthy eggs.
Do you ever give a safe level of alcohol consumption?
From studies that have looked at different amounts of alcohol consumption, generally 3 drinks a week or less has been shown to be optimal compared to obviously more alcohol use. I have a lot of patients who just want to cut everything out. They want to go as clean as possible. I tell them, if that's what you want to do, 100% go for it. That is ideal. But other patients want to have a drink or two on the weekends or at a work event. I reassure them that as you're preparing for this treatment, as long as you keep that goal in mind, I'm comfortable with that. And I think you're doing the right things for yourself. That's the goals that we set for that. The next thing I generally talk about is caffeine. That's another brought up a lot with fertility. This is where men get off the hook a little bit more. Caffeine doesn't seem to have much of an impact on sperm quality, but we do see that high amounts of caffeine can have a negative impact on fertility outcomes, probably from vasoconstriction, blood flow, and health to the ovaries and uterus. It's the same thing as alcohol. It's not something that has to be cut out completely. Some patients feel the most comfortable going completely clean, and that's great. There's no downside to that. But levels that have been studied is about 200 milligrams of caffeine a day seems to be just as good as no caffeine from an outcomes perspective. So that's the target they set. For most people, that might be 1 cup of coffee a day. Just trying to manage that, keep that in mind. And most patients can be pretty successful with that.
Keeping in mind that energy drinks and Coke all have caffeine.
Exactly.
People just think of coffee for the caffeine and forget other things that have caffeine.
Yes, there are many sources of caffeine. They have to be thoughtful about that. And then the main one is diet. That's a big one where I think people can focus and improve their dietary habits. It's easy to slip in that.
Right.
But similarly, there's no magic fruit. Eating
pineapple core isn't going to do the trick.
might not be as beneficial as Google would tell you, but it's the same idea of being mindful about your diet. Taking in a healthy diet is going to optimize somebody's fertility. That generally means eating fresh foods, fruits, vegetables, seafood, fish. Those things are generally shown to be improve fertility outcomes. And then the other main thing to focus on is trying to avoid processed foods as much as somebody can. Because definitely we have seen there are certain chemicals in those types of foods that do have a negative impact on sperm quality, on egg quality, on overall reproductive health. So trying to eliminate those, I think, is an easy thing that people can focus on that really has a major impact. Those are some of the lifestyle changes that we talk about. And then, of course, there's all the supplements, right? That patients are reading about, or a lot of times they come to me and they're already on a whole list of supplements that somebody had recommended to them. So
there's also books out there that patients are reading that are giving specific supplement recommendations.
Yeah, and I think we have to be careful. We have to be cautious there, just not to overpromise. I think a lot of patients read that information and have the expectation that these are medications that are really going to reverse egg quality or the number of eggs that somebody has. I generally explain to patients that unfortunately, we're just not there yet. We don't have treatments that can really improve in a meaningful way their egg quality or egg quantity. And that's where the fertility preservation piece comes in. Right. Egg freezing is our current treatment to do that, putting healthy eggs away now so that somebody has those available in the future if they need them. But there are definitely various supplements out there that have some theoretical benefits, some biological mechanism that could play a role in follicular development and the health of the egg. And so those are the main ones that you hear about. Of course, I would say CoQ10 is probably the most common one. It's an antioxidant involved with follicular development. And that's where that particular supplement came from. Perhaps if we add more of this, and maybe the follicles are deficient, then we can improve their development and follicle health. The challenging thing with most supplements is that they just haven't really been studied in a rigorous way. And we don't have any data that really says, without a doubt, this is beneficial or this is harmful. That's true for most of those supplements. DHEA is another common one that patients often
always controversial in our field.
So then that always leads the conversation to, okay, what is the potential or what is the proposed benefit of this medication or supplement? And then are there any potential downsides? Is there potential harm here? And if a patient is taking a supplement that I think could be harmful or I've seen be harmful in the past, those are the ones that I strongly recommend patients probably should avoid. If they want to take a supplement that has potential benefit, that hasn't been shown to be harmful, I'm supportive of that. I don't think that there's necessarily any specific vitamin other than what's recommended by society and typically what's supplemented in a prenatal vitamin that is necessarily going to have a major impact on egg quality or quantity.
Yeah, I feel like we're really divided in the fertility world from the physician standpoint, where a lot of doctors say, well, we're really deficient in these things in our diet. Even if you're trying to do the best job you can, you're missing out on things. Realistically, the prenatals are probably covering most of those micronutrients that you're missing. I think there's also a lot of talk about, aside from CoQ10, now there's more popularity about acetylcysteine and NAD in the form of NMN, because these are powerful antioxidants that could theoretically improve your reproductive health. But the data is just really lacking.
Yeah. And so that's where we as physicians, our job is to really guide patients towards treatments that have been shown to be beneficial and that we know are making meaningful impact. But there are so many interventions in our field that sort of fall into that gray area. And I think that's where it really becomes an individualized conversation with the patient, specific to their history and their goals and their potential treatments as to maybe what makes sense and understanding what things could be harmful, what things probably should be avoided.
Now, are there other specific things that you do in preparation? Let's say treatment was delayed and now the patient has really diminished ovarian reserve. Do you do any sort of long-term priming of the ovaries in hopes of getting a maximal response or possibly recruiting more follicles and therefore more eggs?
I think there are different ways to prime the ovary, which essentially means we're trying to synchronize that group of follicles.
Right.
When we do the ultrasound, we see the antral follicles. I explain to the patient that it's generally that pool of antral follicles that the ovary's already started to recruit on its own, that now we're taking over and finishing the recruitment of those follicles. In an ideal situation, we want as many of those follicles as we can, and we want them to be around the same point of development so that they grow well together, so that they're all maturing around the same time, rather than if a cohort of follicles grows asynchronously, that's when you end up with some large follicles, some small follicles, and that's a less ideal
fewer eggs result. Yeah,
exactly. So my approach is to try to prime the ovaries before pretty much any stimulation cycle, because it's so simple to do.
Right.
And there's really no downside to it. That's just about a week of estrogen medication kind of leading up to somebody's
I do the same.
Day one. And I see really nice even recruitment with that. Yeah. I think if you don't do that, you get one of those spread out cohorts, and then you look back and think, all right, next time we'll synchronize it. I generally approach that for patients with diminished ovarian reserve. Those are the ones who are more likely to have that spread out cohort. But really for nearly all patients who are starting on cycle day 2 or 3, their treatment leading in with a priming medication is no downside with possible benefit.
Do you have your patients monitor the cycle before to let you know when they've ovulated and confirm ovulation?
There's so many different ways to monitor when to start that medication. Some people will bring them into the office around the time of ovulation or a week after ovulation to check blood work and confirm. I find for most patients, they're already comfortable monitoring for ovulation. They've already been doing it while they've been trying to conceive. That as long as they have regular cycles, I just have them monitor at home, with usually ovulation predictor kits or something like that. And then they just let me know, okay, I've ovulated. And then generally about a week later, they'll start the estrogen. So it saves them that extra visit to the clinic. It's easier for the patient. And it's a very successful approach.
I do it the exact same way. The only time I bring in patients is if I feel like maybe they're a little confused on how to accurately monitor their ovulation. And then I want to ensure that we know where they're at in their cycle.
Exactly. Yeah. It's those patients who have very irregular cycles.
Yeah.
So we don't necessarily know what's going on, or maybe they're monitoring for ovulation and they're just not detecting a surge. Yeah, it wasn't clear. Then that's when we say, okay, just come on in. Let's take a look and see where you're at. And then we'll know for sure. So similar approach, individualized for each scenario.
And I've read some studies showing that raised priming specifically can also help improve the response of the FSH receptor when you give follicle stimulating hormone in an injectable form.
Yeah, that is the interesting part. Even FSH itself, we wonder if prior exposure to FSH might help future follicles to respond. Patients doing back-to-back cycles versus spacing cycles out. It's the same idea. Those follicles were just recently exposed to estradiol and now exposed to FSH and LH. Does that make them more receptive? Have they upregulated their receptors in response to that? And now they're going to be more likely to recruit and develop in that setting. I think that's still a little bit of an area of debate, but it's an interesting thing that we're looking at always. How can we optimize a patient's outcomes? A common question when we're doing treatments and we already know a patient is doing more than one cycle, the question becomes, okay, when can I do the second cycle? Patients ask you that all the time. We've studied that as well. A patient will get a period about 10 days after the retrieval. We can start again with that period, or we can take a month or two off. And that kind of gets back to now we're delaying the treatment by a couple of months, theoretically. We already talked about that delay is not going to have a clinically significant impact. Starting sooner, we don't really see that the outcomes are better. Patients that start right away have a similar outcome in terms of number of eggs and embryo quality.
You find that it was worse.
We didn't find any clinically significant decline there. I generally tell patients, we'll wait and see how you're feeling after the retrieval. Everybody recovers different. Right. Some people feel great. Others have longer recovery.
Right.
And so patients usually know pretty quickly what they want to do. Some folks they're in the groove of treatment. They just want to go through this and be done as quickly as possible. Those are the ones we usually bring them back in with that next period. Always take a look at the ovaries. Occasionally I'll see that all of a sudden there's way less follicles than that patient had at baseline. And so the ovaries seem to be suppressed. And then that's a case where we'll take a month because those follicles are resetting. There's always a new cohort coming through. In those cases, we'll take time. But as long as there's a good number of follicles there like we're expecting, then we'll get started. On the other hand, you have patients who just completed this cycle. They've been coming into the clinic for these visits. They don't feel themselves. They haven't been able to exercise. Some patients just want to take some time to get back to their normal routine, feel their 100% self again, similar to making those lifestyle changes. I want them to feel fully prepared when they're starting the cycle. So those are patients that usually will take a month or two, give them some time to feel ready, and then we'll come back and do the treatment cycle. But in those cases, I don't worry that there's going to be any decline, any impact. So I encourage them to do what they feel is the best thing for them.
Now, for those who go back to back, do you ever prime immediately after, like a week after the retrieval, or do you sort of do a straight start?
I often will prime. I'll do the similar approach where a week after the retrieval, I'll add the estrogen back on. Those patients have supraphysiologic estradiol and progesterone levels after the retrieval. That's probably doing a similar thing with priming. Generally, I'll go ahead and add the estradiol again because there's not much downside. It's only going to help keep things synchronized as they come in to start the next cycle.
That's great.
Yeah.
Now, is there a particular age or AMH level where someone wants to delay treatment for supplementation? Lifestyle-wise, they're really focusing on whole foods, Mediterranean style diet. Primary form of protein is either plant or fish. They have the high fiber carbohydrates, mostly vegetables, legumes, whatever. They're exercising well and taking their prenatals, vitamin D, whatever they need. But now they're really trying to focus on all these extra supplements. Is there a point in time based on age or image where you would say, I really don't recommend that you delay for this particular purpose?
I generally feel very comfortable with a couple month delay. I don't think there's a specific age. I don't think there's a specific ovarian reserve where 2-month delay or 3-month delay is going to make a meaningful difference, a meaningful decline. I will tell patients if they're making some small change that I don't think is going to have a meaningful improvement, that I don't think they need to delay 2 or 3 months. Most patients understand that, and maybe they'll start the intervention, but we'll begin the treatment within a month or two. If somebody really feels like this intervention is important to them and they think it's going to make a meaningful impact and they really want to give it the full 2 to 3 month period, I want that patient to feel fully prepared that they did everything that they could, regardless of the outcome. We both know 100%. We put our full effort, our full energy, and did everything we could to help them be successful. And then generally at the end of the day, regardless of the outcome, we know that we did everything that we could. Hopefully it's a successful one. So in those cases, I am generally supportive. I certainly give a stronger recommendation not to wait more than we don't know what a 6-month decline or a 12-month decline would do. Eventually, yes, there's going to be a tipping point. where now they're going to be doing actual harm.
Right.
And so that's the conversation we have. So we just
Yeah.
find, okay, what's a good middle ground? How much time do we want to wait? We'll get everything set up and start at that time. If somebody happens to have very low ovarian reserve and perhaps we're having a few follicles that develop, there's 2 or 3 eggs retrieved, that might happen if we do a treatment cycle a month from now. It might happen if we do a cycle 3 months from now. I think that's reasonable. That's what the patient wants to do.
I love the approach that you give them that freedom to feel their best going into their treatment cycle.
Yeah, I think it's critical. Fertility treatment takes a physical toll, but it takes an emotional and mental toll as well. I find that patients who are in a good mental space and have good support going into the treatment cycle generally have the smoothest road as they go through it. Patients who are feeling unstable, patients who don't have a good support system, that's where it can have an impact. You see that clinically sometimes.
Yeah.
You see how that can really impact the outcomes of their treatment. So I think that is an important thing not to overlook. Yeah.
Yeah. Love that philosophy. So it seems like the main takeaway really is, if you're trying to improve overall health, if you're even trying to do some supplementation based on your own readings, and that's going to make you feel happier, comfortable, that you could delay 2 to 3 months and it probably will not impact your treatment outcome, but really reconsider if you're trying to delay 6 to 12 months just for specific lifestyle factors, unless it's really necessary. So thank you so much for being here and for going through all of this. Can you tell our listeners where to find you?
Yeah, absolutely. I'm a reproductive endocrinology and infertility physician based out of New York City in Manhattan. So you can find me at RMA of New York in our Manhattan office in the Upper East Side.
Amazing. Thanks again, Phil.
Thank you.